last year pharmacology. Okay, chalo, fine then. So, okay, okay, okay. Chalo. So let us continue, and let us see that what are the various kinds of anesthetics which are present over there. And definitely we also are going to talk about the various features which are present along with. So like there are some very important features which are present, and we will not go into very much detail which are like unnecessary details. So we will talk about some features. So to make it very easy for you, let me first give you the idea that we are going to talk about number one as procaine. Okay, then I'm going to talk a little bit about something called as propoxycane. Propoxycane, and these are very old primitive things, primitive drugs. And then I'm going to talk about something called as chlorprocaine. So you see, they are all similar sounding names. Procaine, then propoxycane, then chlorprocaine, and then we can talk about, like you said, lidocaine. We can talk about mepivecane. Then we can talk about prilocaine. Okay, we can also talk something about like bupivacaine. There is a another drug, bupivacaine, and etidocaine. Etidocaine. Even there is something called as ropivacaine also. Okay, but we will talk about that later on. So we have to talk about these few drugs. And what are we going to talk about it? So there are certain things which I'm like making it very clear what are we going to talk about. So we are going to talk about the chemistry. Very simple. We'll talk about the chemistry. We will talk about the pharmacology. We will talk about the duration, and we are going to talk about the dosage. Okay, so these are the most important things, and these are like useful things, and these are basic things that one should know. So as far as the this procaine is concerned, so we are talking about this procaine thing. So you see, as far as procaine is concerned, so remember that earlier days, like around 1905, during that time, this was considered as the standard of comparison for NELA. Okay, like if you read the textbooks, you will come to know that suppose we talk about, say, propoxycane. So the potency of propoxycane is provided in comparison to procaine. So, like in the book, it will be written that uh, potency is 2. That means if it is written potency is 2, that means it is 2 times that of procaine. If it will be written like toxicity is 2, that means it is double toxic than that of procaine. So that was like the very old time. That was the time when this procaine was considered the gold standard. So we are talking about this procaine. Now remember, as far as the chemistry is concerned, here the melting point which is present, melting point is 60 degrees centigrade, and it is water soluble. Okay, it is water soluble, and it is alkaline. Okay, it has got a high pH. So since it is itself alkaline in nature, so to balance the situation, it is always combined with a HCl. Okay, so it is available as procaine HCl. So it is always yeah, like put in the combination with HCl, because then it will be freely soluble in water, and it will be having a pH of around 4.5. Okay, so there will be a pH of around 4.5. Okay. Now the thing is this: we can it can withstand boiling also. So we can also go for something called as autoclaving. Okay, so we can boil it, and also we can autoclave it. So this is the short story of procaine. Now, as far as the pharmacology is concerned, now why we do not use this procaine nowadays? The reason is this: weak. Nobody loves weak. Okay, and if we talk about being weak, so nowadays it's a fast life, so nobody will look for anything which is like weak anesthetic. And as far as the duration is concerned, it is going to have 30 to 45 minutes. Okay, and dosage should be max 20 milligram at any one point of time you are providing. So these are the certain details of procaine. Now moving on to the next drug, that is propoxyphene. So as far as this propoxyphene is concerned, like once again the chemical properties, so it is white. Okay, propoxyphene we are talking about. Which I think I should go with alternate colors so that, so let's talk about this propoxyphene. So it is white, colorless, like whitish colorless, that kind of thing, white or colorless powder. And of course, once again, it is water soluble. Now it has got a very very high melting point. Okay, it has got a melting point of 148 to 150 degrees centigrade. Okay, and same over here. Here also we use it as the HCl salt. So these are certain. Unfortunately, these are certain data that you have to remember. But it will be very easy once you start comparing the data. So that is why I'm putting all of the things in front of you, so that you can remember it by comparison. Like this is less than this is more than that, that is more than this, less than that. So in this way, like you can have some correlation, and thereby you can understand. So otherwise, talking about each one, either way you have to remember it, but that might be a little bit difficult. So that is why I'm putting all the things over here on the sides only. Okay, so over here the melting point is 148 to 150 degrees, and also remember that it has a pH of 5.5. So last time it was C 4.5, now it is a little bit higher pH, that is 5.5. Now, here, as far as propoxyphene is concerned, remember it is more potent, more potent, and more toxic as compared to procaine. Comparison is always with procaine. So it is more potent and more toxic as compared to procaine. Now, there is one you can say good thing also, that it has got like rapid anesthesia onset. Onset is very very rapid. Now what happens is that whenever we use propoxyphene, so in propoxyphene there is always a mixture of 2% procaine, and so normally used with 2% procaine. This is how we use it normally. Okay, because an onset of anesthesia is very very rapid, and the duration is 1 to 1.5 hours if you are going for extraction. But because this is for the pulpal anesthesia. Okay, if you are going for root canal, if you are going for extraction, then pulpal anesthesia you are going to get 1 to 1.5 hours. But as far as the flap elevations are concerned, soft tissue anesthesia is even more, like almost double, like 3 hours, 2 to 3 hours. So this is the pulpal anesthesia. But as far as the soft, 1 to 1.5 hours. Okay, it's 1 to 1.5 hours for pulpal. Huh, sure. Mhm. Okay, so it is 1 to 1.5 hour for pulpal anesthesia. It is 1 to 1.5 hour for pulpal anesthesia, and it is going to be 2 to 3 hour, 2 to 3 hour for the soft tissue. Now, as far as the dosage is concerned, the dosage is almost 6.6 milligrams per kg. That means if there is a 70 kg person, okay, the average weight that we consider of a man, male weight. So if it is a 70 kg person, that means it will be something somewhat more than 420 milligrams. So it is 420 milligram is coming up for a 70 kg person, because if you see like 70 into, or 700 multiplied by 66, so how much it is coming? 46. And then so it is basically uh, this much. So this much is coming up, isn't it? 46200. So normally, now here remember that it should not exceed, the dose should not exceed 400 milligram. So basically for adults, you should not give more than 400 milligrams. Now at this point of time, I want you to know that there is one more thing that you should be aware about. So there is something called as EMLA. So you can pronounce it as EMLA or you can call it EMLA. What is EMLA? So E for eutectic mixture. EM is for eutectic mixture, and LA, though you know what is LA. Definitely it is not Los Angeles. And eutectic mixture of LA is very, very strong thing. Here what is done is, here 2.5% of lignocaine, plus there will be another discussion like this one. Prelocaine is present over here. So that is 2.5% of prelocaine will be present. Okay, will which you should know. But remember, this is used primarily topically. Okay. Acha, chalo, we'll discuss about topical later on. Let's not put on the topicals over here. Let's deal with the injectables first. But okay, let it be. So moving on. So I guess this procaine and propoxygen is clear, right? So if this procaine, so if the procaine and propoxygen is clear, now we talk about the chlorprocaine. Now let us see what is this chlorprocaine. Now chlorprocaine, remember, it is again white. Now this time there is no colorless business. It is white crystalline powder. Okay, and it has got a even higher melting point. So look at the trend, how the melting point is increasing. So it is white crystalline. It is white crystalline. Of course, just like the previous one, it is also water soluble, and it has got a melting point of 173 to 176. So we started with 60 degrees, then we went on to 148 to 150 degrees. Now we are into 170 to 180 degrees, almost, like I'm just giving you a basic idea. And here also it is used as a HCl salt. So definitely we will get, since over here also we are like using the acid, so here also we are going to get a milta julta similar amount of pH. So the pH is 4.8, and same good thing is present that we had in case of this propoxygen, that is it can be autoclaved, like you can actually boil it or you can actually autoclave it also, like it can withstand that heat. Okay, so this is the idea. Now as far as the pharmacology is concerned, so remember, it is, now here comes up the twist in the story. It is more potent. Now I told you Whenever I say more potent, that means I'm comparing it with procaine. I'm comparing it with procaine. So it is more potent than procaine, but it is less toxic. Good news. It is less toxic than procaine. So this is like better. Like propoxygen, see, whenever you understand it in this way, then a little bit of information you will be able to retain. So if we compare it in this way, so there was something called as procaine. Then when we saw propoxygen, so propoxygen was good at work, but it was more dangerous than that of procaine. So it was both highly potent as well as highly toxic. But if we talk about chlorprocaine, so chlorprocaine has got the good thing that it is more potent, but it is less toxic. That means like it is more like of our benefit over here. Now another thing is it's even 4 to 5 times faster hydrolyzed. 4 to 5 times faster hydrolyzed. So if hydrolysis is going so rapidly, okay, if hydrolysis is going so rapidly, what do you think? Half life should increase, decrease, or remain same? Hydrolysis মানে hydrolysis মানে the elimination is going very rapid. So if elimination is going very rapid because hydrolysis is faster, so half life, do you think should be elongated? Yes. So I hope you understood that it will be having a very, very short half-life. So it is 4 to 5 times faster than faster hydrolyzed than procaine. And definitely it has got a short T half. This is how we write it, short half-life. Okay. It has but it has got a rapid onset of action. Okay, because it is more potent. So you can remember it in this way. So if it is more potent, that means its onset of action is very rapid, but it will wear off also very rapidly because half life is very, very short, and metabolism takes place very rapidly. Now as far as the duration is concerned, duration hence should be like the duration of anesthesia should be more or less like previous one, 1 to 1.5 hour. Okay, so do you think it should be more than 1 to 1.5 hour, or it should be less than 1 to 1.5 hour? So you are saying, so you are saying that it should be like more on like, suppose I inject you with the anesthetic, and you are saying it will take more than 1 to 1.5 hours to begin with the anesthesia. But if you look at this thing, see, you have to find the answer from the given data only. Okay, so how can we find out the data from from the given data? How can we find out? So if you observe, what have we written? We have written that it is more potent. So more potent means what can we expect? Rapid onset of action or slow onset of action? Rapid, right? So yes. So over here, remember, it is very, very short. It's less than 30 minutes. Even procaine was 30 to 45 minutes, but this one is only less than 30 minutes. So its duration is very, very short. And as far as the dosage is concerned, it is 11 milligram per kg. So if a 1 kg person, 1 kg baby is there, there is no 1 kg baby actually. But anyway, just hypothetically, if there is a 1 kg, some alien, somebody, you can give it 11 milligrams. So if we talk about once again, an average individual of 70 kg, so it is supposed to be, you understand, 770 milligrams. And you see, the in pharmacology, I guess you have studied in previous class, there is something called as therapeutic index or the therapeutic window. You see why we don't use these drugs nowadays. It has got such a narrow therapeutic window. See, it is what we are seeing, 70 kg person means 770 milligram. Now here the dose should not exceed 800 milligram. So there is like, if there is an error of 30 milligram, there will be a high tendency of toxicity coming up. So these are some like real time problems which are present over here. So this is the story of dosage. Okay, so next we talk about the this thing, lidocaine, our favorite, the one that we use. So basically I think everybody should be knowledgeable about something that they use. So as far as the lidocaine is concerned, it is also white crystalline. Okay, and its melting point its melting point is almost 69 degrees centigrade. And just like till now, all have been water soluble. So is this. This is also water soluble. Okay. And once again, we use it as HCl. Because I think if you go into your maxillofacial department, maxillofacial surgery department, and you take up the vial of the lignox, okay, lignocaine, or I think you use lignocaine. So over there it will be written that it is lignocaine hydrochloride, okay, lignocaine HCl. So that lignocaine is used as HCl only. So I think you will be able to remember it very thoroughly. And once again, it can be boiled, it can be autoclaved. So about the boiling and autoclaving thing, okay, we are seeing that almost everybody is capable of doing like undergoing the boiling thing. Now, as far as the pharmacology is concerned, the good part is it readily diffuses to through the soft tissue, the interstitium. Okay, so ready diffusion. I'm writing in short, ready diffusion, and it also can go into the lipid-rich nerves because nerves are covered by the myelin sheath, so there will be a lot of lipid. Even nerve it's itself a cell, so definitely it will be having cell membrane and a plasma membrane, so it will have phospholipid bilayer, so lipid is present over there. So this can actually go through the lipid. And normally what do we do when we do anesthesia? Mainly we perform nerve block. So when you perform nerve block, so your anesthetic must diffuse through the nerve membrane. So that's what we see, that there is a ready diffusion which is taking place. And over here, remember, it is two times more potent and toxic as procaine. Okay. So comparison is always with procaine. So when I say two times more potent, that means as compared to procaine only. So here I said that it is two times more potent. Once again, I'm asking you this question. What do you think? Onset of action should be rapid or should be slow? The onset of action, it should be rapid or it should be slow? What do you? Very good. Yes, it is going to be very, very rapid. Like it is as rapid as if I write over here, it will be like 2 to 3 minutes. So, many people, what they do is, I don't know whether you have seen or not, but during our days, a lot of people they used to read less, and they will try to treat the patients as they have seen other doctors to do. Now, earlier, what used to happen, like people didn't take up this profession like very seriously. So it was more like, and a lot of quackery was involved in it. So what they would do is that, first when patients will come up, and earlier there was no such treatment stuff long back. So there were only two solutions. and primarily in India I'm talking about. So there were only two solutions. One is get the tooth extracted. You are having tooth pain, fine. Number one, get the tooth extracted. Number two, take painkiller and just stay like that and wait when the pain will subside. There was only two options, nothing more in India primarily for the regular middle class people. So whenever there will be a dentist present, so called, so that person has got primarily one job to do, that is extraction. Because usually if you have to get it extracted, the amount that you will be paying, earlier I'm talking about, the amount that you will be paying, and medicine and consultation almost same. And patients used to think, like one day you pay the doctor for consultation, it is temporary relief. So again another day you have to go to the doctor, and then the doctor is going to again charge for it. So why going for it? Better let it be finished in one go. So what these doctors would do those days is they would make the patient sit in a waiting area. Now what they will do is they will call everybody one by one, like say five patients or six patients. Okay, they will call one by one by one. Actually, you come up, then they'll push anesthesia. Okay, you go. Then you come up, push anesthesia. Okay, go. So first, in set of five or six, they will just put anesthesia, 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 anesthesia. After fifth person anesthesia is done, now they will call up the first patient. That okay, katash, extraction finished. Next patient, again talk, extraction finished. Again talk, extraction finished. No, earlier days there used to be a lot of concepts, like they would not go for firm tooth extraction. They will tell the patient that see, this tooth is not mobile. Okay, so they will wait when the tooth is mobile and all. Even patient parties all used to be like that. They will take medicine, like for 6 months, 7 months they will just take painkillers and they will not go to the doctor. So like they will visit the doctor when maybe the tooth is completely broken, a few chotu roots are present. So like the doctor would just bring it out like that. Plus another thing is, when you will when you do the patients, I always tell the the observers in my chamber that the trick in extraction in exodoncia, first trick lies in your anesthesia. If your anesthesia is good, patient is not going to give you any complaint. You do whatever, it's like the complete playground for you. You do whatever you feel like inside the patient, and of course don't do harm, but like you do whatever you can do, provided you are good in your anesthesiology. So if you're good at that, then your first trouble is gone. But if you are not good at this topic that we are discussing today, if you're not good at anesthesia, then even if the surgery is easy, that this tooth is very mobile, I'll just bring it out, I'll deliver the tooth in like 10 minutes, 15 minutes, 7 minutes, 5 minutes. But you won't be able to do that, because patient will keep jumping around on the chair. Patient will keep jumping in pain. Why? Because your anesthesia was not good. If your anesthesia is good, you break the tooth, you open up flap, do some more elevation, you bring out the root, maybe you go transalveolar, maybe you cut the bone, you do some bone drilling, or you make a burr hole in the bone. Whatever you do, patient is not going to have any complaint. Because patient knows that doctor is doing something, I'm seeing it, but I'm not feeling anything. So patient becomes more confident on you, and patient becomes more relaxed in front of you. So earlier days this used to happen. So what I have seen, a lot of the people, when I was learning, they used to make the patient sit for 10-15 minutes. But then I read it, and it says that onset of anesthesia is 2 to 3 minutes. So I started doing it in 2 to 3 minutes. I saw even some of the postgrads and teachers, they are also doing it in 2 to 3 minutes, 5 minutes, and everybody was successful, and I was also becoming successful. So then I understood that this is basically a myth going on. You don't need to wait for a long time. Earlier they would do it for number one, patient management, and number two is, more you wait, even if your anesthesia is not good, it will diffuse, and like after half an hour, so definitely it will go into the depth of the where the nerve is present. So, and another reason is this, that nowadays we are dental surgeons. So we are more of a surgical people. We know the knickknacks of surgery. We know the knickknacks of anesthesia. Earlier, it was not the case, and primarily not in case of the quacks. What they would do is they would identify the tooth, and what they will do is they will put the injection in the vestibule, and it worked in case of maxilla. Why? Because maxillary bone is cortical bone. Diffusion can take place easily. So, and last class also we have discussed it, that sometimes it can diffuse through the bone also, and cortical bone is very easy for diffusion. So in maxilla, though, it is fine, but mandibular bone is not cortical; it is cancellous bone. So in mandible, how will the thing diffuse? In mandible, it was not possible. In mandible, patients will shout and scream and all these things. So this used to be the problem. So in mandible, if you are asking the patient to wait, so sooner or later, somehow it will diffuse, and it will go, even if your anesthesia is not correct. So this was the advantage for making the patient sit. So if you are not confident that whether you have given anesthesia properly or not, ask the patient to sit, wait. But if you are confident with the location of anesthesia, where you have placed the anesthesia, if you're confident on that, then no point. Like, you can just wait for just 2 to 3 minutes, and you can, start doing the extraction or whatever surgery you felt like. So, its time is 2 to 3 minutes. Got the point? The duration. Okay. So next, what we have? Next, we have got the duration. Sorry, this was the onset. 2 to 3 minutes is the onset. The duration is almost 1 hour. Okay. So let it be like 30 to 75 minutes. Now, as far as the dose is concerned, it is 4. Now, this is something that you should know because we use it currently. So you should know the dose. And I'm going to have more discussion on this later on. So the dose is 4.4 milligram per kg. So you see, if it is 4.4 milligram per kg, so once again, if we have 70 kg individual, okay, and there is, you have to like calculate that how much should it be. So how much it is? 7 fours are 28. So it is like this, 308. So you can use 308 milligram. But remember one thing, you should not exceed 300 milligrams. You should not exceed that. You should not exceed 300 milligram when not accompanied by a vasoconstrictor. Without vasoconstrictor, you should not exceed 300 milligram. But if you are using with vasoconstrictor, then it becomes 7 milligram per kg. Okay, and if it is 7 milligram per kg, that means how much it is coming up? It is coming out to be 490 milligram. So remember this, that here you should not exceed, it should be less than 500 milligrams. This is with vasoconstrictor. Now, why? With vasoconstrictor, why the permission is more? Why without vasoconstrictor permission is less? Can you tell? We have had a earlier lecture on vasoconstrictor. You have seen that lecture. So can you tell that why it is 7 milligram? More liberty is given for with vasoconstrictor, but less liberty is given for without vasoconstrictor. See, if vasoconstrictor is given, so vessels are all constricted. So what do you think? The drug would flush out from the zone of surgery, or it will more remain concentrated in the zone of surgery if there is vasoconstrictor, and all the vessels everywhere in that area is blood vessels are all constricted. So the anesthesia that you have given over there, think and answer, the anesthesia that you have given over there, that anesthesia will go away, or that anesthesia that you have deposited over there will remain over there? Tell me this. You're mute. Very good. So of course it will remain over there. So if it remains over there, so like you understand that um, it is not going to have the toxicity. It is not going to spread throughout the body. It will remain localized over there. But if you are without the vasoconstrictor you're using, then as soon as you use it, then it is, it will spread throughout the body. So you cannot give more. So that is the reason why we use like with vasoconstrictor. So it also increases our dosing capability. We can, there is a less chance of overdose in this case. Okay. So coming back, so we talk about now our beautiful this thing, mepivacaine. Oops. All right. So let's have a discussion on another thing, that is mepivacaine. Now, mepivacaine, see, after chlorprocaine, what we saw, melting point is has reduced. Initially, the melting point was increasing. Look at the trend. Initially, we started with what, 60 degrees, then we went on to 148, 150, then we went on to 170, 176, then it dropped to 69. Now it will be again on the lower side only. So remember, this is also white crystalline or colorless. So it is also white crystalline, or it can be colorless as well. And here the melting point, last time it was what, 69, it was in the 60s, now it is going to be in the 260s. So the melting point is going to be 260 or 261 degrees centigrade. Once again it is going to be water soluble, and once again it is HCl. I don't think we should talk about this because they are all common. Okay, these are all having HCl only, and they are all, whatever we have discussed, they are all water soluble. And remember that it is resistant to acid and alkaline hydrolysis. Okay, so it has got a high, like it can be again autoclaved. Okay, so one thing you should remember, that it is resistant to acid and alkaline hydrolysis. Now then we have got what, pharmacology. Now remember, it is same as that of lidocaine. The pharmacology is same as that of lidocaine, and it is it has a moderately long duration of action. Okay, this is the only thing that you remember. So normally, mepivacaine is used as a 3% concentration. Okay, 3% concentration without vasoconstrictor, and 2% concentration with vasoconstrictor. I hope you understand the reason why it is more concentrated without vasoconstrictor, because it just spread out, so it will get diluted. So it, over there concentration is used is more. But if it is localized with vasoconstrictor, if it is localized present in that area, then we can use little bit less concentration over there. Okay, and duration is also similar over here. It is going to be like 20 to 40 minutes. Okay, and in case there is no vasoconstrictor, and maximum dose is once again 6.6 milligram per kg, and not to exceed 400. Where did we learn this? We learned it in case of, see, propoxycane. See, this is the reason we are discussing these things in this chart form. So here you can have that comparison, and when you have that comparison, you will be able to remember it. So got the point? So over here, this is these are some, beauty of the various kinds of, local anesthetics that we are using. Moving on. So next thing that we can have, that is a prelocaine. So here I was talking about that, lidocaine and the prelocaine wala mixture, that was called as the EMLA, eutectic mixture of local anesthesia. So it's like 2.5% of the lidocaine and 2.5% of prelocaine. But let's understand what prelocaine is all about. So remember, prelocaine, what is so special about prelocaine? So speciality of prelocaine is, okay, prelocaine is a derivative of toluidine. It is a toluidine derivative. Of course, hydrochloride salt is used, and you see, its melting point. Last time it was what? See, again, we have got a rhythm here. What is the rhythm? Last time we saw 260. Now we will see 160. Okay, so now the melting point is going to be 160. Actually, it is 167 to 168 degrees. But at least if you can remember the trend, if you don't want to remember the 67 or 60, you can simply remember that around 160, that one is around 260. Okay, so you can write it in that way if asked for, or if it is a multiple choice question, then you will be able to identify the correct option. So this is about the melting point, and it is again water soluble, just like rest of them are, and it has got a pH of 6 to 7. So you see, it's on the alkaline side, and of course you understand it has to be on the alkaline side because that is the reason why we are using the hydrochloride salt. We are using HCl as the salt, and similar to the rest of them, that here also we can go for autoclaving, and we can also go for boiling. That means sterilization in is not at all a issue in none of these cases as of now. Now, as far as the pharmacology is concerned, once again, it is similar to that of lidocaine. Okay, similar to that of lidocaine. But as far as the central nervous system is concerned, CNS toxicity is less. Okay, CNS toxicity is less. That's good sign, no? It will not affect the brain much. So it has got a less CNS toxicity. But another good thing, or you can say as a clinician it will be bad, but for patient it is good that it has got a very high biotransformation. So it has got a very very high biotransformation, rapid biotransformation, and if biotransformation is high, so you can correlate from here. I don't know whether if you can. So can you tell me if biotransformation is fast again? Okay, listen to the question and answer properly. If biotransformation rate is faster, so the absorption from the injection site should be faster or it should be slower? Absorption from the injection site should be faster or slower? Of course, very good. So here remember that the absorption is faster as compared to lidocaine. So it has got a faster absorption from the definitely the site of injection. Now here remember two things. Acha, okay, one thing I'll talk about, that is orthotoluidine. Now this is very very important and special, and everybody should be thorough about it. Orthotoluidine. What to talk over here? This is a metabolite which is formed while biotransformation. This is very, very important. One metabolite that is formed while biotransformation is orthotoluidine. Now, orthotoluidine produces something called as methemoglobinemia. I hope you understand what is methemoglobin. Methemoglobin is, it is a hemoglobin in which iron is already present in ferric state. So definitely it will not have any capability to carry oxygen. And if it does not have any capability to carry oxygen, that means it is useless. So that is something called as uh, your methemoglobin. Now, normally, how much methemoglobin do we have? Normally, we have got approximately say 2 to 3% of methemoglobin present in our body. Now, if it is more than 2 to 3%, so we call it as methemoglobinemia. So, methemoglobinemia occurs due to orthotoluidine as well. And prilocaine has got a metabolite of orthotoluidine. So, if there is a patient who has a known methemoglobinemia condition, should you prefer prilocaine over there? No, yes. So remember that is the contraindication. Okay, so as far as this prilocaine is concerned, remember this, that it has it is available in 4%. Oh, okay. It is available in 4% solution. So we are not using it in case of methemoglobinemia patient. And the duration you should remember, it is 60 minutes without the vasoconstrictor, and with vasoconstrictor, you understand. anesthesia level should increase because it remains over there. So definitely it is 90 minute with vasoconstrictor. Okay, so this part is clear about prelocan. So if you if, huh, if you are capable of if you see the chart as a whole, then it can be very horrific. So do not try to see the chart as a whole. Do the chart one by one by one. Use some comparative studies. Okay, that okay, this is more here, this is less here, this is less than that, this is more than this. So you will remember some data. Of course, the entire data might be difficult, or it might not be easy in a single go. But if you can have some correlation between all of these, then after a few times of revision, I think you can make it up. Okay, so moving on to the three more are left. Bupivacaine. Let's talk about this bupivacaine and see what's here in bupivacaine. So as far as this bupivacaine is concerned, once again, this is white crystalline powder, and white crystalline powder. It is also water soluble. Okay, remember one thing people say, it's written in the books also, that it is not only soluble in water, but it is also soluble in a very interesting thing, ethanol. Okay, it is also soluble in ethanol. Okay, and its pH is 4.5 to 6.5. Now remember that it is similar to mepivacaine. Why? Because this is also amide derivative. Okay, this is a amide derivative. I hope in pharmacology you have studied, if you remember, some local anesthetics are ester derivatives and some are amide derivatives. So this one is amide derivatives. Okay, so and boiling and autoclaving again, like it can be done. Now remember, it has 4 times more intrinsic anesthetic activity as compared to mepivacaine. So here we are comparing it with mepivacaine. So it is 4 times better than mepivacaine. And it is, then why didn't I discuss about bupivacaine earlier? It is better, but no, even toxicity is 4 times more. So it is 4 times more potent as well as more toxic. But again, prolongation of anesthesia is good. But why will I use it? It is 4 times more toxic. Sorry, it is 4 times more toxic not only as compared to mepivacaine, but it is also 4 times more toxic as compared to lidocaine. So basically, the normal that we use, that is lidocaine. This is 4 times more toxic than that. Of course, nobody will dare to use it. Now, okay. Now remember, there is over here there is a period of analgesia that persists even after return of other sensations. So you can remember it more importantly for anesthesia. Sorry, analgesia, not anesthesia, but analgesia. Do you know what is the difference between anesthesia and analgesia? Anesthesia means numbness. Pain will be gone, sensation will be gone, and in sensation I mean touch, temperature, pressure, everything will be gone. But here, what I'm trying to say is that in bupivacaine injection, even when the sensations have come up, but analgesia is still present. Man, painkiller. It has got a good property of killing pain. Okay, so sensations will return back, but pain will not return back so easily. So that's one good part about this bupivacaine. Okay, and its duration, hence its duration can be 3 to 12 hours, depending on what you want. You want loss of sensation, then initially there will be loss of sensation. But when loss of sensation is getting away and sensation is getting gained, the person is gradually getting back the sensation, analgesia is still there. So such a huge range of duration of action, 3 to 12 hour. Okay, and then the maximum dose is 2 milligram per kg with, of course, with vasoconstrictor. But here remember, you should not exceed more than 220, you should not exceed more than 225 milligram. This is with vasoconstrictor. And if it is without vasoconstrictor, so what do you think? Without vasoconstrictor, we should lower the maximum dose, or we should increase the maximum dose without vasoconstrictor? Mind it. Uh, my question is, see, with vasoconstrictor, my question is, with vasoconstrictor, we are using maximum recommended dose of 225 milligram. Now, my question is that with vasoconstrictor, I should increase this amount or I should decrease the amount? Like this one, 225, this one is with vasoconstrictor. My question is, what about without? Correct. All right. Um, Mute, please. So, uh, can you mute? Huh. Okay. So, without the vasoconstrictor, it is 175 milligram. Okay. So, without vasoconstrictor, you are right. So, it has to be less. So, it is 175 milligram. And finally, not finally actually, the like second last you can say. So, we can have etidocaine. Etidocaine is also white, it is also crystalline, it is also water soluble. Okay, it has got a pH of 3 to 5. Okay, 3 to 5 is the pH. Now, it has got a faster onset and it has got a longer duration than lignocaine. Fast and long. Than whom? Than lignocaine. But remember this, bupivacaine, we were comparing it with mepi. See, it is similar sounding, na? Mepi, bupi. So bupi is always compared with mepi. When I said bupi is 4 times more potent as compared to whom? Mepi. Okay, so remember this. Bupi is not compared with ligno. Bupi is compared with mepi. But rest, when I say etido, etido is compared with lido. So we are again comparing with lido. So you can remember etido with lido. So it is faster and long acting than lidocaine or lignocaine. And remember that it has 4 times, once again, it's 4 times better action than lido, and duration of action is also twice twice duration of action, and it is 4 times more potent. So as you understand, this is good, this is good. And its duration is approximately say 180 minutes, because how much was this lido? 1 hour I said. So 1 hour, and this one is double of that, so almost 2 hours. So you see, it is almost 3 hours. So it is like, not like we are saying that 2 times, but it's almost like 3 times. है ना? So it's good. But remember, dosage over here is 400 milligrams per kg, and without vasoconstrictor, and you should not exceed 300 milligram. So strange. Okay, sorry, it is like, I think it is 4 milligram per kg, not 400, 4 milligram per kg, and it should not exceed less than 300 milligram. But if it is like with vasoconstrictor, so at that time we can increase a little bit. So it is 4.4 milligram per kg, again not to exceed 400 milligram. I think now you are understanding the trend. how the with vasoconstrictor we are applying the dose, without vasoconstrictor we are applying the dose. Is that concept coming up? Okay. So if this concept has come up, so I will talk about two more over here, so that like if I do two more, then I think like we can finish the overall injectables. Watch, I can go on this side. So let's go on this side only then. Okay. So the next two which are left, one is called as ropivacaine. Ropivacaine, and another one is centbucridine. Centbucridine. So there is ropivacaine and then there is centbucridine. So as far as this ropivacaine is concerned, now what is this? So let's talk about it. So ropivacaine is again similar to. Acha, you tell me, according to the naming thing that the naming game that I'm playing, Ropi should be compared with Ropi. The name is Ropi. So it should be compared with, yes, or maybe, or Bupi. Correct. So yes, mute yourself. So it is similar to Bupi and Mepi. See, it's becoming so simple. And problem is, it has less motor blocking capability. Okay, less motor blocking capability and less cardiotoxicity. This is good. So less cardiotoxicity and less motor blocking capability. Usually, if you use ropivacaine, you are going to use a concentration of 2.5 to 1%, and the maximum dose should be 300 milligram. Okay, you don't need to know nothing more over here more than this. And just to talk about a little bit of the centbucridine. So remember, it is 9 butyl amino 1, 2, 3, 4 tetrahydroacridine. I haven't counted the letters over here, but who knows that it becomes more than what do you say, the longest letter. 9 butyl amino 1, 2, 3, 4 tetrahydroacridine. Okay, so this is the chemical name, and this is what I wanted you to know about centbucridine. And actually, there is a compound called as 9 amino tetrahydroacridine. So there is a 9 amino tetrahydroacridine. I'm writing it in short. So basically, this is a derivative of that. So it is like when you do some modification in this 9 amino tetrahydroacridine, then you are going to get 9 butyl amino 1, 2, 3, 4 tetrahydroacridine. Now, as far as the potency is concerned, so remember, it is five times more potent as a centbucridine. We are going to compare it with whom? What do you think? Let's see how you have understood the trend. We should compare it with what? Okay. If you observe, we have left Prilogen long back. Now, all these latest ones, they are mainly compared with. But it is the main gold standard right now, other than Prelo. Sorry, Prelo was never the gold standard. PPN was there, but other than that, yes, Lido. Etido was compared with Lido. Everybody is getting compared with Lido only. Okay, so mute yourself. So Senbucridine, yes, Senbucridine is five times more potent. Five times more potent as compared to lidocaine. Okay, and if you are using Senbucridine, one good part is one good part about sandbucridine is you do not use vasoconstrictor. Okay, because this anesthetic itself has a vasoconstrictor property. That is the special about that. This is the reason why I'm discussing this, because sandbucridine speciality is you do not need to use a vasoconstrictor along with it. It already its own property is vasoconstriction. So why do you use it? And okay, it has anesthetic and fallopian occluding property. Now this is something that you should remember. It is constricting, na. So definitely it has got a fallopian occluding properties, and definitely it acts as a CNS stimulant. It can act on CNS as stimulant as well as depress like vasodepressor. Okay, I'll write it for you. So stimulant, CNS, then vessel, blood vessel. It is a vasodepressor. What else? What other adjective can we use? It is antihistaminic. It is antihistaminic, and it is also spasmolytic. What do you mean by the word spasmolytic? Lysis means, so spasmo. So breaking down spasm means causing spasm or relieving from spasm. Yes. Okay. So I guess you got it. Mute yourself, please, once again. So once we have discussed this part, now we can move ahead and we can talk about something called as the topical anesthetics, because we have something like topical anesthesia. Huh? Sure. Okay. So mute yourself, then we can continue. All right. So having said this thing, now we can talk about a little bit of topicals, topical anesthetics. So as far as the topical anesthetics are concerned, topical. So first we are going to talk about something called as water soluble. Okay. So first thing is going to be the water soluble. Now under water soluble, first we will be talking about the thing called as, let's say, benzocaine. We will talk about. I think this is very very common. Benzocaine. I use it a lot. It is there in my chamber. Like it is water insoluble. So what is benzocaine, first of all, that we need to know. So remember, ester of it is ester of amino benzoic acid. The word is benzocaine. No? So amino benzoic acid. So it is unable to form any salt. because for forming salt you have to, you understand, it has to be polar. So it is water insoluble. And since it is water insoluble, it has got another property, that is, if you inject it by chance, it is going to act as a tissue irritant. Okay, and like due to that irritation, it can create a lot of toxic symptoms also. Okay, if it goes into the circulation. And like you understand, we have discussed, it is water insoluble, so definitely it has got a low water solubility. So if it is water insoluble, what do you think? It will be more readily flushed away, or it will more remain in that location? Whenever things flush away, they dissolve with what? Right. So the benefit is this: is the anesthesia will be prolonged. Anesthesia will be prolonged, but toxicity will be reduced because it is not going into systemic circulation. So toxicity is getting reduced. But since it is not going into the circulation, so anesthesia is also getting prolonged. So this is the reason why I use specifically benzocaine in my chamber a lot. Okay, so it is like, I think if you have a little bit of money in your practice, then definitely you can afford, or you should go for benzocaine. But then, if we talk about water insoluble, actually, why did I write water here? It is, it, people can, or you can think that it is water soluble we are talking about. So it is water insoluble. Okay, so that is benzocaine. Now talking about the lidocaine. Okay, so next thing that we can talk about, that is the lidocaine base. Lidocaine base. Now, why did I write lidocaine base? You will understand after a while. Just for the time being, trust me that it is lidocaine base. Now, as far as this lidocaine base is concerned, it is, if insoluble in water, of course, we are talking about that only. So we use it as 5% concentration. And here it gives you anesthesia with approximately 15 seconds. Okay. And more it is kept in contact with the mucosa, more longer anesthesia it will provide. Okay, so this is true. And if you are applying for a single time, then it will stay for 30 minutes. Okay, half an hour it will stay. Now you tell me, topical anesthesia, systemic toxicity. Okay, forget about whether it is lido or benzo, it is topical. So what do you think, systemic toxicity should be high or it should be low? It is topical anesthesia, so systemic toxicity should be high or low? Of course. So systemic toxicity is low over here. So simple. Okay. So let us proceed ahead and let us talk about this time about the water soluble. So we will talk about the water soluble ones. And here the first thing that we should be talking about is basically, which one to use? Let's use this one. So we'll talk about something called as benzyl alcohol. Benzyl alcohol. So as far as benzyl alcohol is concerned, what is it? It is an aromatic alcohol. That is first you have to remember. Okay, it is a aromatic alcohol, and it is used in almost 4% to 10% solution. Okay. Problem is we do not use it much. Why we do not use it much? Because of short duration. Okay, it has got terrific short duration. Now, then again, we can talk about another thing that is called as tetracane. Tetracane. Have you heard of tetracane before, or like first time tetracane? I think first time you're hearing it. Right. So remember, tetracaine is very potent. Tetracaine is highly potent. It is, of course, as we are discussing, water soluble. So tetracaine is water soluble. Tetracaine is highly potent. Okay, so high potency is present, and we use 2% solution. Okay. Now there is a problem with tetracaine. That is, this tetracaine can actually dissolve with blood. So if tetracaine has the capability to dissolve in blood, okay, it can uh, absorbed in circulation. So if it is absorbed in circulation, that means chances of toxicity should be correct. So high chance of toxicity. See, these are all connected. Okay, you apply logic and you will be able to understand it. Now, if it is getting absorbed in circulation more and more and more, so naturally it will take a little bit of time to kick in. The anesthesia will take a little bit of time to kick in. So here we can say that the anesthesia is going to be like slow onset of action, slow onset, but long lasting. Onset is slow, but it can be long lasting. Okay. So normally it is, how do we use it? It is used in combination. It is not used alone. It is used in combination with benzo, and its maximum recommended dose is 20 milligram or 1 ml 2% solution. Okay, 1 ml 2%. It's a 2% solution. Okay, so what is 2% solution? Remember, 2% solution means 2 unit in 100 ml. So in 100 ml, normally we use say 2 grams. Okay, so in 100 ml, we are going to use what? 2 gram or what? How much should we use? Like I said that 1 ml 2% solution. Acha, okay. So, you're not very comfortable in this calculation. Huh, no, like that is the question. Can, are you capable of calculating the percentage of maximum recommended dose? How is maximum recommended dose calculated? Do you have idea about that? No, no. Like my question. Suppose it is given Lignox 2%. So what do you mean by that? 100 ml, 2 ml or 2 gram? Yes. So, it is in, right. So it is always in gram. So it is 2 gram. Okay. So this is how we calculate it. So if it is 2 gram in 100 ml, so then we can say that it is 100. Sorry, it's 2%. Got the point? But anyway, chalo, that's a different discussion. So 2 grams in 100 ml. Yes. So tetracaine plus benzocaine, we will be using it. That combination we will be using maximum 20 milligram. Huh. So that is like how will you use it in that way? It is a complete mixture which comes up. You cannot separate it. Getting? Suppose 2 gram in 100 ml. Okay? So in 1 ml, how much is present? It is 0.02 gram. So 0.02 gram, if you convert it into milligram, so how much should it be? 0.02 gram, if you convert it into milligram, how much should it be? I think this is very easy. Like, don't take too much pressure. Just relax. Huh. 0.02 gram, as it is written over here, into milligram, I'm saying. Gram to milligram is multiplied by 1000. Do you know this? Gram, then if it is 0.2 gram, can you calculate it in milligram? How much should it be? See, 0.02 multiplied by 100. So what happens is the decimal goes in this direction. And if it is 1000, then it will be another one. See, when you multiply, decimal shifts on right side. When you divide, decimal shifts on left side. So it is supposed to be 20 milligram. Okay. All right. Huh. So, huh. So you see, that is what is written over here. See, that's what is 20 milligram here. So either 20 milligram or 1 ml, 2%. Getting the hold of it. All right. Now moving on. Let's change the topic. Let's talk about lidocaine. Mute yourself, please. Lidocaine hydrochloride. Now see, this is something which I have written here. Last time when I was mentioning about water insoluble thing, I mentioned lidocaine base. Now when I'm mentioning lidocaine hydrochloride, I'm mentioning it under water soluble. So this one is hydrochloride. So now it can readily, diffuse in the water. So we are calling it as lidocaine hydrochloride. So as far as lidocaine hydrochloride is concerned, we use it as again 2% to 4% concentration. And over here, this is water soluble. So water insoluble should be more toxic, or this like lidocaine base should be more toxic, or lidocaine hydrochloride should be more toxic? It is more polar, right? So penetrability should be more. It can travel with blood anywhere. Correct. So it can penetrate into the tissues more. All right. So it has, but it is also, side effects will also be more. So it has like increased penetration capability, and definitely because of the same reason it will be having increased toxicity. Okay, and remember the maximum recommended dose is 200 milligrams. Okay, so normally 1 to 5 ml, okay, or zero point 0.6 to 3 milligram per kg. It is available. Oral gargles are available, oral mouthwashes are available. So this is that concentration that is used usually. So if you're using, say, 1 to 5 ml, that means it will be like somewhere around 40 to 200 milligram. Okay, you didn't get how. See, when I said percentage, na, so 2% to 4%. So once again, you have to calculate just like the tetracaine wala thing, and then you will see. Okay, anyways, chalo, you can calculate it slowly. Right now, I think you will be confusing again. So that remember one thing, that if you are using in this way, say 0.3, oh, sorry, 0.6 to 3 milligram per kg, just like I've written. So it should not exceed 300 milligram. This is also true. You have to remember this. So got the idea? All right. So I think I have covered the different types of drugs which are used over here in this local anesthetics, and I think next time we meet, we will be talking about the local anesthetic that we use. Okay, so today I gave you a glimpse of how we calculate. So be aware about it. And the next day we meet, I'm going to actually talk about the details of the anesthesia or anesthetics that we use in our practice, because you have to know what are its components, what is it made up of, who is the vehicle, what is the preservative. So we have to know all those details. So that we are going to discuss later. Okay, so let's wind it up today, it here only. Okay.